Welcome back. We will continue with the part 2 of the GIT pathology, that is, first coming to inflammatory bowel disease. In inflammatory bowel disease, it is immune mediated chronic intestinal inflammatory condition. It may be of two types, that is ulcerative colitis and Crohn's disease. The etiology of this IBD, it may be genetic factors, environmental factors, host factors. IBD susceptibility genes, there are three. Those are NOD2, CARD15. CARD15 or NOD2 are present on the chromosome 16q, also known as IBD1 locus, ETG16L1 gene, and IRGM. It responds to infection and clear infective agents. NOD2 for recognition and response against microbes in the intestinal lumen. These are the genes. Now coming to environmental factors of IBD, it may be intestinal microflora, smoking. In host factors, we can see it may be due to epithelial defects, defective mucosal immune response. There may be imbalance between pro-inflammatory and inflammatory mediators, which leads to uncontrolled inflammation. Now coming to Crohn's disease, this Crohn's disease is abnormal defensins in the patients with ETG16L1 mutation. TH cells involved here are TH1 T cell, TH2 T cell, and TH17. Coming to pathogenesis of IBD, here we can see the transepithelial influx of bacterial components through the intestinal epithelial cells occur. These bacterial components are presented to dendritic cell, that is antigen presenting cell, where the complex is formed. This complex leads to T cell activation, which releases IL-12. This CD4 T cell leads to production of TH17, TH2, and TH1. This TH1, by producing the factor IFN gamma to the macrophages, it leads to increase in the permeability of the epithelial cells, which increase the entry of bacterial component into intestinal epithelial cells. Or it may also produce a TNF, which also increases the permeability and it increases the entry of bacterial components into the intestinal epithelial cells. Now coming to TH cells, TH2, this T helper 2, it produces IL-13. IL-13, it also increases the permeability. Now coming to this antigen presenting cell, it produces IL-23, which helps TH17 cells, which produces IL-17 to release a neutrophil. This neutrophil infiltration can be seen in this layer. This leads to inflammatory bowel disease, which is further explained. Crohn's disease, it is a chronic progressive inflammatory bowel disease. It is in terminal ileum. Features are, we can remember these features by the mnemonic of sister in CCF. Here, it may be skip lesions. Ileum is most common. String sign on radiology, transmural inflammation, extensive fibrosis, rectum spelled, intermittent attack with cloaky abdominal pain, non-caseating granuloma, cobblestone appearance on mucosa, creeping fat on serosa, fistula may develop. The clinical feature of this Crohn's disease are iron deficiency anemia, malabsorption, stricture formation, fistula formation, acute complication, carcinoma development, cystic amyloidosis. Ulcerative colitis. This ulcerative colitis, it is severe ulcerating inflammatory bowel disease. It leads to inflammation only in the mucosa and submucosa. Features of this ulcerative colitis, that is, it can be remembered by the mnemonic, that is cold tip. Cryptitis, crypt abscesses, it originates in the rectum, and it is limited to colonic and submucosa, as I said above. Distortion of the crypts, and there will be decrease in the mucin. Toxic megacolon, increase in colonic cancer, pseudopolypsis. Now coming to early acute ulcerative colitis. Here we can see mucosal congestion, edema, cryptitis and crypt abscesses, chronic inflammatory cells. Granuloma and skip lesions are not seen in this feature. It can be remembered by 4 C's, that is C for congestion, C for crypt abscesses, C for crypt distortion, and chronic inflammation. Now 4 M's. Here 4 M's are mucosal atrophy, decrease in the mucin, metaplasia, and mucosal dysplasia. The complications of this colitis are there is toxic megacolon, it develops at colorectal carcinoma, intestinal hemorrhage, electrolytic imbalance can be seen. Now coming to polyps of the colon, here polyps, mass that protrudes into the lumen of the gut, mainly sigmoid colon, most common site for polyps and cancer. The polyps are of two types, that is sessile, there is absence of the stalk, and pedunculated, there the stalk will be present. There is another type, that is a non-neoplastic type or neoplastic type. In non-neoplastic type, it is inflammatory, hamartomas, and hyperplastic. In neoplastic, it is benign or malignant. In hamartomas, it may be of sporadically or part of the genetic disease. There is an important syndrome associated with these polyps. It is known as juvenile polyps coli syndrome. In this, we can see there is multiple juvenile distributed throughout the colon. There will be increased risk of colonic adenocarcinoma. There is another syndrome which is known as Pets-Ziegler syndrome. It is autosomal dominant, STK11 gene on chromosome 19, multiple GI hamartomas, polyps, and mucocutaneous hyperpigmentation. It is the most important part of this Pets-Ziegler syndrome, which increases the risk of colon, pancreas, breast, etc. Gardner syndrome. This Gardner syndrome, it is extraintestinal manifestations of familial adenomatous polyposis are prominent. The intestinal manifestations are similar or like those of osteomas of the skull, mandible, etc. There is another tumor, it is known as Turcot syndrome. Turcot syndrome, the colonic adenomas with tumors of CNS, that is medulloblastomas. Next, there is hereditary non-polyposis colorectal cancer, or it is known as Link syndrome. It is caused by the mutation in the DNA mismatch repair gene. It is autosomal dominant. Next, colorectal cancer. This colorectal cancer, it leads to adenocarcinoma. Dietary factors for this colorectal cancer are low intake of dietary fibers, high intake of refined carbs and fats, deficiency of vitamin A, vitamin E, vitamin C. Coming to pathogenesis of this colorectal cancer, it may be of two types, that is a genetic and epigenetic abnormalities. In genetic, we can see of two types, that is adenoma carcinoma sequence. In this, there will be inactivation of APC tumor suppression gene, which leads to both copy of the APC gene inactivated. Then this inactivated APC gene leads to accumulation of beta catenin, and this beta catenin now combines with TCF and the complex is formed. This complex leads to the activation of a CMYC gene and cyclin D1 gene. It leads to cell proliferation. This proliferation leads to adenocarcinoma, and this is an important sequence we must remember in this adenocarcinoma. Then, other than inactivation of the ACP tumor suppression gene, there is mutation of KRAS gene. This KRAS gene mutation, it leads to cell proliferation and it prevents apoptosis. Other mutations are SMAD2 and SMAD4 gene mutation, TP53 mutation, and activation of telomerase. This activation leads to expression of telomerase. It increases the progression of the lesion. There is another part which contributes to the genetic factors, that is a microsatellite instability pathway. This microsatellite instability pathway, it is of three mutations can be seen here, that is a type 2 TGF beta receptor mutation. It leads to uncontrolled cell growth, pro-apoptotic Bax mutation, and BRAF oncogene mutation. Coming to carcinoma colon, this is an important. Here it is exophytic polypoid mass in the right colon, Annular constricting mass in the left colon can be seen. In right colon, we see exophytic polypoid mass, and in left colon, we see annular constricting mass. This mass can be of napkin or apple core constriction, diffuse tubular tumors, infiltrative and ulcerating tumors. What is signet ring carcinoma? This signet ring carcinoma, it consists of signet ring cells similar to those in the gastric cancer. Coming to macroscopic varieties of this carcinoma of colon, here we can see polypoid growth in the proximal colon, then annular carcinoma tubercular part. Here we can see polypoid cauliflower growth. This cauliflower growth is seen in this part. Ulcerative type of carcinoma colon and infiltrating and ulcerative. Adenocarcinoma of tumor or tumor cells arranged in glandular part. Here, muscle layer infiltrated by the malignant tumor can be seen here. We can see the malignant tumor has infiltrated the muscular layer. This malignant infiltrated by the malignant tumor, it is seen in the glandular pattern. The neoplastic glands can be seen here. Now coming to investigations. Investigations are occult blood, tumor marker increase, the increase in the carcinoembryonic antigen and CA19-9. Another investigation is sigmoidoscopy can be done. On radiology, apple core appearance is seen. This is an important for NEET PG. Apple core appearance is seen in the radiology of these patients. Prognostic factors are depth of the invasion and lymph node status. The last topic in this part is acute appendicitis. In acute appendicitis, there is acute inflammatory process. Pain starts in the periumbilical region and it shifts to the right iliac fossa. In lab findings, we can see there is increase in the WBC count, microscopic hematuria. The most important sign in acute appendicitis, it is McBurney's sign. It is a deep tenderness located 2/3 of the distance from the umbilicus to the right anterior superior iliac spine. The complications of this appendicitis, it leads to gangrenous appendicitis, perforations, portal venous thrombosis, liver abscesses, and bacteremia. Thank you. For more such videos, please share, subscribe, and comment down below whatever questions you may have, or you may need any other further explanation for such topics. Please subscribe our channel for more such videos. Thank you.